primary basis, but I think that in 6 months we will be able to do primary PCI. But we do other things in the cath lab. We do interventional catheterization. This is a double balloon pulmonary valvuloplasty. We do Röntgen procedure in TGI. We have a program to do also mitral commissurotomy and others procedure, which is on an ongoing plan. So when we deal with the delay in Africa, you see in Burkina it's very high, in Senegal also, and it is very, very long. So we have to do something to lower the delay, and the mortality, of course, is high. And in our context, thrombolysis should be, of course, the first choice, and it should be available very quickly. We have to work on and to make it available very quickly to the patient. Of course, the other treatments are mandatory. And rescue PCI should be a second choice. And thrombolysis in pre-hospital basis is very effective, as you see. If you wait to go to the hospital, the cardiac event and the amount of myocardial infarction will be very, very more important. So, to conclude, thrombolysis is a very good alternative. It has proven reduction in mortality, and in our context, we have to work on and to make it available very quickly by emergency medical system to build up. Cardiac intensive care also is a very important objective. Development in interventional cardiology is on an ongoing process. We have to promote it, and sensibilization of the population to shorten the delay is also an objective. And creativity is very important to manage, and we have to deal with, of course, to resolve our problem and not to be tapped in a hole. Thank you very much.
Thank you very much for a very elaborate lecture, very inspiring. Can the two speakers come to the round table for questions?
Now, in the last 3 years, we've had 102 patients with coronary artery disease that we have picked up. Average age was about 60, with a Euro score of 4.2. Of these, a quarter had significant stenosis, over 70%. And we had PCI done in 48 patients, about 62% of them. Now, of these 48 patients, we had PCI done for either MI or unstable angina in 81%, and that PCI was either stenting in 85% and just PTCA in 14% with good outcomes. Now, some of our challenges have been the cost of these procedures. The angio alone cost $250,000 in Nigeria, which is about $1,500 US. Each stent from the manufacturer costs about the same amount. So a patient who has a single lesion, by the time he has the angio and stenting, he's spending about $3,000. In India, this costs only $200 to $50. So it's a challenge which we are facing, which we'd like to see what your experience is. The other thing is, of the patients who had PCI, the PCI was for either MI or unstable angina. Only 40% had thrombolysis, mainly because the agents available to us, which we use, is tenecteplase, but from the manufacturer, also very expensive. One vial cost 400,000 naira. That is about just over $2,500 US. How does an African patient afford that? So we can't just put that on the shelf. So only the rich patients really have been the beneficiary of this program so far. So just how to extend this to the general population, we obviously need government support. So I think maybe as we collaborate, we can bring down the cost and make PCI more available to more people. Thank you.
Thank you.
I'd like to know, how much does it cost for a patient to have that and then to be transported to the hospital? And what is the response time from when the ambulance crew gets the phone call to when they get to the patient? And then I'd like to ask Dr. Mrs. Jan, how do you see us establishing such a service in our country or to start with in our capital?
I want it established that the data that Dr. Jan presented is not that of Korle Bu Teaching Hospital. The enormity of the problem is more than what she actually presented. These are the data from the National Cardiothoracic Center. And we see but the tip of the iceberg as far as patients with acute coronary syndromes are concerned. Perhaps I should say the lucky few who are able to get into our center come there. The large majority go to the emergency room in Korle Bu Teaching Hospital and they do whatever they can for them. I don't want to preempt the answer of Dr. Jan, but there are private ambulance services in Ghana. We have the West African Rescue, and they are quite capable of doing thrombolysis during the transport. They have very well-equipped ambulances. They are established in Accra, and they have now established themselves in Kumasi. Fortunately, there are plans that are far advanced. In fact, with our help from our colleagues from Medtronic, yesterday we had delivery of coronary stents and then catheters. So at the National Cardiothoracic Center, we are going to commence PCI when our interventional cardiologist returns from his leave in 2 weeks' time. Again, there are plans that are very far advanced for the Medtronic Foundation to establish a new cath lab at the National Cardiothoracic Center. And this will have facilities for all sorts of interventions that are presently available. Talking about peripheral vascular disease, also, we have Dr. Adade, who just returned from India, and he had a lot of experience in stenting of peripheral vascular diseases. And the cath lab that is proposed will have facilities for all this. That is just what I wanted to clarify.
In our series, we found that only 68% of the patients underwent PCI. The reason for that is there were a number of stenosis that were too long, too irregular for PCI. So 38% of them required CABG. At the time this study was done, we didn't have sustainable cardiac programs. So part of the outcome of that study is that there are patients out there who need both the interventional cardiologist and the surgeon. You do your angio, and then you make your decision based on what is best for that patient. But just to stress that, that's why we work together, surgeons and cardiologists.
So I would like to say that in Dakar, thrombolysis is available in 3 hospitals and in 3 private clinics. It is available. And we have 3 regions far from Dakar which are implementing this technique. So for the private ambulance, the cost of the treatment is 150 euro for septokinase, and it can raise to 2,000 euro for Techniplas, because Techniplas is very expensive. So insurance company or tourists coming and people which are covered usually choose Techniplas. And for the national emergency medical system, which is governmental, thrombolysis is not until now in the ambulance, but they can go, make the diagnosis, and transfer to a hospital which can do thrombolysis.
Yes. In practice, there is sometimes difficulty in diagnosing no-ST elevation. I will ask Dr. Jan to elaborate a bit on that.
The problem with non-ST, as I showed you, that a lot of the times the ECG may be totally normal. The patient has symptoms suggestive of acute myocardial infarction. As I said, sometimes they could have atypical symptoms, and you do an ECG, and the ECG is normal. Sometimes you may have some ST segment depression, so then it will let you say, okay, something is going on with the myocardium there. So once the patient comes in with symptoms, and the patient comes in, the history is very, very important. And in the history, you should try to pick up key things like risk factors that the patient has. What are the risk factors present for the patient? And then it's also important if there's family history too of coronary artery disease. How early too the family or the family members had this acute myocardial infarction or maybe even unstable angina. And then you go on to do your ECG. If the ECG is negative, then we need to do the biomarkers for the patient. We need also to repeat the ECG for the patient. Really, they shouldn't go home, but we should follow them up closely. Repeat and then to do an echo for the patient. The echo is going to be very helpful to show us if there's any regional wall motion abnormalities. And then that too will suggest that there's an ischemic process taking place. Sometimes, too, there's a delay, even in the rise, how sudden the patient comes in, the changes in the ECG to be shown. So sometimes the patient may not show, but as time progresses, you may get signs suggestive of it. And then even sometimes before the patient is discharged, then it would be good, if possible, to do other tests, diagnostic tests for them, like maybe even a stress ECG test for the patient. And that, too, is very helpful in telling you whether the patient has acute coronary syndrome.
Thank you very much. I think by the number of questions, I can deduce that the two lectures have been very, very clear. So I would invite you to give them a loud round of applause. Thank you very much.
Thank you very much, Professor John Podonu. Thank you, Dr. Jan. Thank you, Professor Diop. We have finally come to the end of this two-day marathon. We've come to our closing ceremony, and may I invite the Director of the National Cardiothoracic Center, Dr. Lawrence Sribo, upstage, the Chairman of the Local Organizing Committee, Dr. Mark Tete, and the President of the Association, Professor Yanni Angate. They will give us their brief remarks. We take a closing prayer, and thank you. So may I invite Dr. Mark Tete for his closing remarks.
President of the West African College of Surgeons, and also the President of our Society, Professor Yanni Angate, the Director of the National Cardiothoracic Center, Dr. Lawrence Sribo. We have to thank God for coming to a successful end. Undoubtedly, you'll agree with me that we've had a fruitful conference so far, and I know that everybody has something to take home. However, I have to confess that it has not been easy at all. On this note, I would like to ask all the members of the LOC to just get up so that we appreciate you, please. Members of the LOC, can you please get up so we know you and everything. Thank you very much for your hard work and all that you have put in to make this conference a success. I sincerely pray that the subsequent conferences of this association will enjoy more participation from all over Africa and beyond. And from the experience we've had so far, I believe that the annual scientific conference of this association can help change the face of the practice of thoracic and cardiovascular surgery on the African continent. May God bless and reward each and every one of you who have sacrificed by traveling from all over the continent to Ghana and then contributed towards the success of this conference. Thank you very much.
Thank you very much, Dr. Maktete. We shall now take remarks from the Director of the National Cardiothoracic Center.
Finally, we've come to the end of this inaugural conference of the association. And I must really commend the local organizing committee for a job that is excellently done and executed. I really commend how efficient everything has been done. And I want the audience to applaud them again for that. I'm happy and I'm proud as the director of the center that we were able to help out financially. Dr. Tete and your team, Ayiko.
Very kind words. Shall we invite Professor Angati?
Dear Deputy Provost of our great University of Ghana, my colleagues, dear LOC Chairman, dear colleagues from Ghana, of course, LOC Chairman with all his team, colleagues coming far from West Africa, next to West Africa. I'm very proud. I am really on the land of the Pan-Africanism. What I have learned here, I have seen here, is the spirit of unity between all Africans, sharing the same challenges, the same problems, the same spirit. I'm very happy to stand